that is more, and conjugated bilirubin, when the direct component is more than 20%, we call it conjugated hyperbilirubinemia. We know this. What is physiological jaundice? So what is physiological? We now call it benign neonatal hyperbilirubinemia. It is an increase in conjugated bilirubin as seen in all newborns, as we know the metabolism now. So why does it happen? It is just a normal transitional phenomenon because the fetal RBCs have a high volume and they come down to adult levels and they have a shorter lifespan, like 85 days as compared to 120 days of normal adult. The newborn's liver is again immature to handle so much of load. And the UDGPT1A1 enzyme is in the newborns. At birth, usually the levels are just about 1%. They reach about 14, they say reach that levels. So conjugation is less, and of course increase enterohepatic circulation because of the sterile gut. So usually we've seen that the peak levels occur between 72 to 120 hours, and mean peak values of total serum bilirubin that we use to calculate bilirubin is 840 milligram%. And usually this normal physiological jaundice or visible jaundice usually resolves by 7 to 10 days. It has been observed that it lingers longer in exclusively breastfed infants and lasts for around 3 weeks. Reasons we'll come to later. When do you call it as a pathological neonatal hyperbilirubinemia? When the onset of jaundice is before 24 hours of age. If any elevation that requires phototherapy, if the rise is rapid, like more than 0.5 milligram% per hour, and if you see any underlying illness also along with the jaundice, then signs of any bilirubin-induced neurological disorders that we'll come to discuss in detail later, and jaundice persisting beyond 14 days. So since unconjugated hyperbilirubin is the main, let us discuss it in detail. So what are the causes for a significant unconjugated hyperbilirubinemia? So as we see, where the load will be more when there is increased hepatic bilirubin load, which will occur, of course, due because of hemolysis or the breakdown of the RBCs. RBC or hemolysis will happen in certain conditions. The immune-mediated hemolysis, like Rh isoamine, as well as minor blood group incompatibilities. Then you can have hemolytic disease due to red cell enzyme deficiencies. Everybody knows about G6PD deficiency, also pyruvate kinase deficiency. Then again, hemolysis due to red cell membrane defects like hereditary spherocytosis, elliptocytosis, stomatocytosis, and pycnosis. These are membrane defects, and the names are morphology seen on the peripheral smear of these. Also, there will be hemolysis in hemoglobinopathies like alpha thalassemias and gamma thalassemias. Also, if there is any extravascular or sequestered blood, like for example, there's a cephalhematoma due to birth trauma or anything. So it's a collection of blood and it will keep on releasing with slow hemolysis, and there will be a rise in bilirubin. Again, polycythemia, increase RBC mass, again more breakdown, again that will also increase the load. Increased load, as you have seen that it is increased enterohepatic circulation, will also increase the bilirubin load and increase unconjugated hyperbilirubinemia. Intestinal obstructions, pyloric stenosis, ileus, meconium plugging, there is slow transition and more absorption, and the load increases. Breast milk jaundice. After the liver has to clear the bilirubin, sometimes there is decreased hepatic clearance of the increased bilirubin that can cause again jaundice. So prematurity, some genetic polymorphisms which impair the hepatic bilirubin uptake. Then this of importance is the bilirubin conjugation disorders due to variations in the enzyme required for conjugation. Crigler-Najjar type 1, type 2, and Gilbert are the known syndromes. Crigler-Najjar type 1 is the most severe form. It has absent enzyme activity, whereas type Hello. No, I think I got back. Yeah, am I audible?
Yes, ma'am. Yes.
Yes. Okay, thanks. So there are certain clinical risk factors suggested by American Academy of Pediatrics, which you should look for and be alert, which are responsible for progressive and severe hyperbilirubinemia in the newborns. Prematurity, hemolytic disorders, early onset of jaundice. If there is a parent or sibling who has required treatment for neonatal jaundice, any family history suggestive of inherited hemolytic disorders, bruising, cephalometoma, infants of diabetic mothers, Down syndrome, and those with exclusive breastfeeding. Then there are risk factors. Yeah, there are risk factors designated for neurotoxicity as well as the unbound bilirubin is toxic. It crosses the blood-brain barrier, and this risk is increased with severity and duration of bilirubin exposure. So those risk factors are gestational age less than 38 weeks, hypoalbuminemia less than 3 gram percent, the alloimmune hemolytic diseases with isoimmunization, G6PD, and other hemolytic conditions, sepsis, and significant instability. They are also they are the risk factors for neurotoxicity. Two, three topics of interest that I would like to touch upon in these causes in a little bit of detail. One is the immune-mediated hemolysis or the hemolytic disease of the newborn, the RH isoimmunization, ABO, and minor blood group incompatibility. So what happens in a hemolytic disease? There is destruction of the fetal or neonatal RBCs. I think again went. So there's destruction of the fetal or neonatal RBCs due to maternal antibodies. This happens when the RBC antigen, which is not present in the mother, gains access to the maternal circulation. As we all know, in RH isoimmunization, they are usually acquired antibodies. It requires sensitization in the mother, and it usually occurs in the first pregnancy. Hence, the subsequent pregnancies are more affected, and the first pregnancy is not, because of circulation, feto-maternal circulation usually occurs during delivery. So unless the mother has received some transfusion or had an abortion as not and not received any anti-D immunoglobulin. So, and ABO incompatibility where the mother is O and baby is A or B, they can present in the first pregnancy itself. How do they present? Most severe form is the hydrops fetalis, which is a life-threatening anemia where the baby presents with edema, ascites, effusions. It is more seen with RH and minor blood group incompatibilities. Then the baby will present with jaundice, which is rapidly progressive in the first 24 hours, and or symptomatic anemia. We will have signs of anemia like tachycardia, lethargy, and all. So when we have this baby, there are situations where you will be anticipating this delivery sometimes with the the RH status of the mother and the antibody titers, or in this case you would evaluate with a you will send your blood CBC, you will send retic count to for as evidence of hemolysis, the bilirubin levels, the direct Coombs test, and of course the blood grouping. So how do you treat? Hydrops is a severe form and it is an emergency. So early transfusion to stabilize. So you use a transfusion rather than exchange to stabilize first, and then you follow it by an exchange transfusion. If it is a severe anemia,
क्लास हो गई खल्लास। दो है मेरे ज्वाइंट।
There's some disturbance in the network. We're not able to see the screen. Just give us a moment till we sort this out.
कहाँ से मिली?
While Dr. Manju and Dr. Abhilasha just log in again, we will have our dietitian, Mrs. Roshan Kore, to start. She's a consultant pediatric nutritionist working in the field of pediatric nutrition and dietetics over last 28 years, providing therapeutic nutrition counseling for children with varied clinical conditions. She's a visiting consultant at SRCC hospital. Over to you, ma'am. Can you hear me?
Yes, ma'am.
Mr. Roshan, can you start? Ms. Roshan, can you hear us? Am I audible to others?
Yeah.
Ms. Roshan, can you please start? We can see your first slide.
Can we restart? If,
Okay, can you hear me?
Hi, Dr.
Dr. Abhilasha, just wait. We have
Okay.
Dr. Ms. Roshan is starting with her topic. Just wait, please.
Okay, fine.
Should I
Yeah.
start now? Can you hear me?
Yes, ma'am. We can hear you.
Okay, so as I was saying, like today's 4-course meal menu has been shuffled a little bit, and we are starting with the dessert, which was supposed to be the last one. So let's hope to leave a sweet taste as we begin again with our session. So the topic given to me is From Milk to Meals, Crafting a Nutritional Path for Neonates. So as we all know, the nutrition of neonates is taken care of by the neonatologist and the nursing team while the baby is in the NICU with ample help from the nursing staff. So why is nutrition so important? Nutritional management is vital to neonates because of the effect it will have on their later outcomes. Nutrition is hampered by immature and dysfunctional GI tract. Poor tolerance of parenteral and enteral nutrition is seen in preterm and sick babies. Small term infants are mature with oromotor function, grow well if allowed breast or standard infant formula ad libitum. Specialized nutritional inputs may be required for the small term infants where comorbidities exist, and preterm formula is not recommended for these infants. It is only meant for preterm infants. Enteral nutrition usually is advised to be started with mother's milk. So what are the benefits of mother's milk? There's a unique benefit over formula for preterm infants. It contains more cysteine and taurine. It has lipase that improves fat absorption. It has long-chain polyunsaturated fatty acids, nucleotides, and gangliosides. It has greater bioavailability of certain trace elements, faster gastric emptying and feed tolerance, immunological and microbial protection to the infant. It transfers milk hormones and growth factors. It reduces risk of infection and necrotizing enterocolitis. Human milk-fed preterm infants have a higher IQ compared to the formula-fed ones. Reduced risk of allergic diseases. First choice for preterm infants is the mother's own milk. There is higher nutrient content than donor milk from the term delivery mother in a preterm mother's milk. Feeding with preterm milk shows better growth. Human milk fortification is usually used to amp the nutritional content of the milk. So satisfactory initial growth rate of preterm infants is achieved through preterm milk. 30 days postpartum, preterm milk is inadequate to meet the requirements of a growing infant. Hence, supplement of preterm milk with human milk fortifier is usually advised. HMF contains bovine whey predominant protein or hydrolysate, glucose polymer or maltodextrin, macronutrients, micronutrients, and vitamins. Multi-component fortification of human milk increases nitrogen retention, growth, and bone mineral content. Fortification is started when 100 ml per kg per day or full enteral feeding is tolerated by the neonate. 180 ml per kg per day of fortified preterm milk is required to achieve optimal nutrition. Against this, the preterm formula is the next best choice when infant's own mother's milk is available. Term or soy formula is nutritionally inadequate for preterm neonate but can be used for the term infant. A preterm formula contains at least 2 grams per 100 ml of proteins or hydrolysates, has 8 to 9 grams per 100 ml of carbs, Lactose content is reduced and substituted with high molecular weight glucose polymer. It has a higher energy of 60 to 70 kilocalories per 100 ml, mineral trace elements and vitamin content. It has normal osmolality and hence better tolerated. Long-chain polyunsaturated fatty acid supplementation in preterm formula increases the rate of visual maturation. Benefits over term formula in improving growth rate and IQ. Evidence-based guidelines for enteral nutrition, the practical, effective, and beneficial. Basically, when it is human milk, it is the first choice of infant's own mother's milk. It can be stored at room temperature for up to 24 hours for colostrum and up to 6 hours for mature milk. Beyond that, refrigerate at 3 to 4 degrees C before use. If unused for more than 5 days, should be frozen. Human milk fortifier indicated in preterm infants of less than 31 weeks or less than 1.5 kgs. It is commenced when infant has graded up to 100 ml per kg per day of milk feeds and discontinued when full breastfeeding is achieved. Formula milk, preterm formula if infant's own mother's milk is unavailable, commenced at a concentration of 60 kilocalorie per 100 ml and should be increased to 80 kilocalorie per 100 ml when infant has achieved full enteral feeding. The evidence-based guidelines for enteral nutrition says that commencements of the feed should be done on an hourly basis of 1 ml in infants less than 1 kg, 2 hourly feeds of 2 ml in infants 1 to 1.5 kg, 3 hourly feeds for 3 ml in infants 1.5 to 2 kg, and 4 hourly feeds of 4 ml in infants weighing more than 2 kg. Unless there is significant respiratory distress, then remain on 1 to 2 hourly feeds. If concerns exist of intolerance or the milk may be commenced at 1 ml every 2 hourly or even 4 to 6 hourly. Such trophic feeding should begin as soon as possible after birth and definitely within 3 to 4 days. Progression of the feeds. Daily increment is in the range of 10 to 30 ml per kg of milk feeds is safe. Demand feeding is started after infant is on full milk feeds on a 4 hourly regimen supplement. A multivitamin supplement is started when full enteral feeds are established, and iron is started only when infant has doubled birth weight, usually at 2 months. MCT can be used as an energy supplement for those preterm infants who fail to thrive. Post-discharge nutrition. This is a very critical period because here the mother is left to her own devices to deal with whatever issues she would be facing with feeding the neonate. So mothers are encouraged to continue breastfeeding after discharge. As healthy preterm babies reach their term, feeding skills improve and hopefully the feeding is easier for the mother. Babies are considered for weaning between 5 and 8 months of uncorrected age and at least 3 months of corrected age. So what are the cues for weaning healthy preterm babies? First, we go by the positioning. Head control and stable head position should be achieved. It can be, the baby can be supported easily in a sitting or position on a lap. Oral skills, can breast, bottle or cup feed efficiently, brings hands to the mouth and explores finger with the mouth, demonstrates munching or up-down jaw movement. And lastly, behavior, alert and appears ready for new type of feeding, shows interest in others eating. So what are the different type of weaning foods that can be given to the baby? We all know about rice gruel or rice kanji, but it is very watery. So it should be used as a starter preparation and slowly the consistency should be made thicker. After rice is tolerated, other grains like ragi sattva, wheat flour, suji, and other amylase-rich flours like sprouted grains powders like the sattva or the sattu can be tried. Once that is tolerated, moong dal, pureed vegetables, pureed fruits should be progressed. So the baby's complementary or weaning foods should basically include all the kitchen foods that can be later on given as normal foods. These would be given in a form of gruels or kanjis or in a blenderized form to begin with, but slowly should be made into mashed preparations. Addition of salt and sugar should be delayed as much as possible. How to ensure that the baby gets all the nutrients from the complementary feeding? For that, we explain the mothers to follow the basic 5 food group principle, where foods are distributed in the 5 main groups containing of grains, vegetables and fruits, milks and other protein alternatives, and fats and oils. A balanced intake of all these meals in the baby's diet will ensure that the baby gets adequate intake of carbohydrates, proteins, omega-3, vitamins, minerals, and all the other nutrients and antioxidants that the baby needs. So basically, it is a balancing act, and the mothers need to be taught how she can include foods like grains and dals combined with vegetables, grains with milk products and fruits, grains with egg or non-veg when the child is a little older with vegetables. Examples would be like a soup with chicken broth, soup with cheese, smoothies, gruels with vegetables, pulses, buttermilk, porridges, milkshakes, theplas or rotis mashed with dal. Now here we are basically talking about an infant or a neonate who has gone on to become a older child with at the age of 9 or 10 months. And when you need to be a little bit bold and start with the normal regular food for the baby, but in a non-spicy and blenderized or mashed form. This will basically form the basic foundation for the child to eat normal full diet as he grows. Many of the NICU babies face sensory-based feeding difficulties as they grow older, and children with feeding difficulty have a restricted quality, quantity, and or variety of food consumed, placing them at high risk of malnutrition, overnutrition, micronutrient deficiency, or toxicity and dehydration. The restricted dietary diversity common in feeding difficulty can have other adverse nutritional consequences. Exclusion of entire food groups such as fruits and vegetables can result in micronutrient deficiency despite adequate macronutrient intake. Children with excessive intake of specific foods, beverages, or dietary supplements, this is at around toddlerhood, experience micronutrient excess or rarely toxicity. Excessive energy intake, especially in the setting of lower energy requirements, can result in obesity. And this is much true for babies who are underweight or premature and low birth weight and are being fed throughout their childhood to achieve the normal weight as compared to other children. And then they end up with obesity as they grow around 7 to 12-year-old. So this is basically the story of a mother and her newborn baby who is left at the mercy of the hospital team to take care of the baby's feeding and well-being. And we have to be sensitive enough to empower her before discharge with the knowledge and the skill to feed the baby so that when she goes home, she is confident enough to feed the baby the normal kitchen feeds and does not depend only on formula feeds. Thank you.
Ms. Roshan, I think we have a question. Why should salt and sugar be avoided as long as possible? By Dr. Priyanka Mota.
So it is said that the baby's requirements are smaller. We are, as it is giving them concentrated feeds with a concept of giving them maximum in minimum volume. Also, the formulas that may be needed have adequate sodium in it. The feeds which are kitchen made are also having the regular salt or the sodium which is present in the foods as such. And hence, so that not to damage the kidneys or cause dehydration in these babies, salt intake is restricted. Sugar is restricted in the initial phases, basically so that we do not put the baby at risk of osmotic diarrhea or to lower the appetite, as we know that excessive sugar can increase or hamper the appetite of the baby. So ideally, in my practice, I tell the parents to restrict using salt as much as possible. It is added only if it is required according to the blood parameters, if it needs to be given in a little extra quantities. Sugar is usually avoided to avoid the risk of later obesity, because we all know that premature infants or low birth weight infants go on to get into obesity in their later childhood.
Thank you, ma'am. We'll now have Dr. Abhilasha to resume her talk. Dr. Abhilasha, are you there?
Yeah, hi.
Yes. If you could just share your screen as well.
Yeah, one
And
second. Very sorry for the interruption and drop of the connection previously. Where do I start? Should I give a gist from the beginning?
if you could just actually quite a bit of it was not visible, the slides. If you could start from the beginning and maybe just go through the first few slides and then discuss the rest in detail.
Okay, one second.
Can you share your slides, Dr. Abhilasha?
Is it visible? Is the screen visible? Yeah, Dr. Rojul?
No, ma'am, no.
Hmm?
Yes, they are visible now.
They're visible now? Okay.
Yes, parts of it.
Should I
Yes.
give a gist from the beginning?
Would be better.
So we were discussing neonatal hyperbilirubinemia, that is elevated level of bilirubin in newborns. And this is a common problem that we face on a day-to-day basis. We've seen cases daily of neonatal jaundice, as it is a physiological phenomenon. And it is better to know when to treat and when not to treat. So elevated levels of serum bilirubin more than 1 milligram percent, that is a normal level. Adults become jaundiced when the levels are more than 2, and newborns appear jaundiced when the levels go beyond 5 and 7. We call it severe and extreme hyperbilirubinemia when the levels are more than 25 or 30 respectively. The incidence of severe or extreme neonatal hyperbilirubinemia is very less, like 0.01%. As we see, 0.2% is the level for severe. The bilirubin metabolism I had explained that to understand what is the rise. So
जायचा वेळ झाली आता आमची रमेश गाडगे
Am I audible? So basically, bilirubin, the free bilirubin joins albumin and is taken to the liver, where it dissociates from the albumin and is conjugated by the liver enzyme uridine diphosphoglucuronate transferase, and it is converted to conjugated bilirubin. The conjugated bilirubin is water soluble and it is excreted through the gut. However, it is not so easy. It is broken down to urobilin and stercobilirubin in the gut by the bacterial enzymes. The newborn's gut is sterile, hence this conversion is limited. Also, the intestinal mucosa has an enzyme beta-glucuronidase which deconjugates the conjugated bilirubin again, and that causes increased hepatic load. That is, the bilirubin again becomes free, and that one is absorbed from the intestinal wall and taken back to the liver. So what are the types? I had said that this one is physiological and pathological, and unconjugated and conjugated neonatal hyperbilirubinemia. So basically, more it is the unconjugated hyperbilirubin, and conjugated hyperbilirubinemia we call when the direct component is more than 20% of the measured. So usually, most of the neonatal hyperbilirubinemia is a benign condition, and the increased unconjugated bilirubin in the newborns is seen because it's a transitional phenomenon, and it occurs because there's a rapid turnover of the fetal RBCs. The fetal RBCs have a high hematocrit of 50 to 60. They have a shorter lifespan for say 80 to 90 days as against 120 in adults. Again, the newborn's liver is immature to handle the bilirubin load because the enzyme responsible for conjugation is just about 1% at birth, activity-wise, and it reaches around 14 weeks, they say. Again, intestinal bacteria are less, hence there is increased intrahepatic circulation. So these are the causes for the physiological rise in the bilirubin levels. And the peak occurs between 3rd to 5th day, that is 70 to 120 hours, and the levels being 8 to 14 milligrams per cent. It usually resolves by 7 to 10 days, we've seen, and it takes longer, it lingers longer in exclusively breastfed infants. You call it pathological when the jaundice lasts for more than 24 hours, any elevation that requires phototherapy, if there's a rapid rise in the bilirubin, say more than 0.5 milligram per cent per hour, or any signs of underlying illness and jaundice persisting beyond 14 days, and of course, signs of bilirubin-induced neurological disorders, which we'll come to later in detail. We had also discussed the causes of significant unconjugated, because this is the major load. Would like to discuss this in detail today. So what are the causes for unconjugated neonatal hyperbilirubinemia? It is basically as we have seen from the metabolism, anything that increases the hemolysis will increase the load for conjugation or the bilirubin load in the body. And hemolytic processes, the causes being, one is immune-mediated hemolysis, that is the Rh isoimmunization, the ABO and the minor blood group incompatibilities. Then we have the RBC enzyme abnormalities, the G6PD and the pyruvate kinase enzyme deficiency. Also, there are red cell membrane defects which cause increased hemolysis. The hereditary spherocytosis, elliptocytosis, stomatocytosis, and pycnocytosis are named as per the morphology seen on peripheral smear. Then again, there's hemolysis in hemoglobinopathies were abnormal, alpha thalassemias and gamma thalassemias because of abnormalities in the chain. Also, if you have sequestered blood like a cephalhematoma, so that is like a constant source of slow hemolysis and again rising bilirubin. If there is any polycythemia, that means there is increased RBC mass and hence more breakdown, that will also cause increased load. Then the increased enterohepatic circulation, that is one entity again which causes increased bilirubin load, because if there is intestinal obstruction or meconium plug, pyloric stenosis, all these conditions cause stasis and increase absorption, deconjugation and increase absorption, thereby increasing the load. And of course, breast milk jaundice. Then if there is decreased clearance also by the liver, that is seen in premature babies, then in hypothyroidism, hypopituitarism, then certain conditions which impair the bilirubin intake, certain genetic polymorphisms. Then there are disorders of bilirubin conjugation, the Crigler-Najjar type 1 and type 2 syndromes, and the Gilbert syndrome. Type 1 is the most severe. There is actually absent enzyme activity which is responsible for the conjugation. Crigler-Najjar type 2 is less severe form. It has some activity, and Gilbert syndrome is due to decreased production of the conjugating enzyme. And the enterohepatic circulation increase that we have discussed as a cause. So there are certain clinical risk factors which cause a progressive and a severe hyperbilirubinemia in the newborns, as given by the American Academy of Pediatrics. These factors are prematurity. The risk increases with each additional week below 40 weeks of gestational age. Hemolytic disorders, the alloimmune, G6PD, and other hemolytic conditions, early onset of jaundice, parent or sibling required treatment, a family history suggestive of inherited hemolytic disorder, bruising, cephalohematoma, macrosomic infant of diabetic mother, Down syndrome, and exclusive breastfeeding. So these are the risk factors for progressive and severe form of hyperbilirubinemia. So you should be alert if any of these are present. And there are certain risk factors which can cause neurotoxicity. They are gestational age less than 38 weeks, albumin less than 3 gram%, the hemolytic disorders, sepsis, or clinically unstable children. So a few topics we would touch in detail. One is the immune-mediated hemolysis or hemolytic disease of the newborn. It is basically caused due to destruction of the fetal or neonatal red blood cells due to maternal antibodies. So the maternal antibodies are caused when the RBC antigen, which is not present or expressed in the mother, gains access to the maternal circulation. In Rh isoimmunization, this usually occurs during delivery. Hence, the firstborns are not so much affected as much as the subsequent pregnancy onwards, because the mother gets sensitized during the first delivery. Unless she has received the foreign antigen with prior transfusions or abortions and not received any anti-D after the abortions. ABO incompatibility, where mother is O and baby is A or B blood group. ABO incompatibility can occur in the first pregnancy itself, as they are naturally occurring antibodies. So how do they present? Usually, if there is an immune hemolysis, or the babies can present in the severest form, that is hydrops fetalis, where there is a life-threatening anemia and edema, ascites, pleural and pericardial effusion. This is more commonly seen with Rh and minor blood group incompatibilities. And you can have a severe jaundice within the first 24 hours, or symptomatic anemia, tachycardia, and failure signs. So in this case, you would send your blood CBC retic count to see for hemolysis, to see the bilirubin load, serum bilirubin. You would do a direct Coombs test as an evidence of presence of antibodies and blood group typing. How would you treat it? If it's a hydrops, it's an emergency because there's severe anemia and failure. So you would do an early transfusions, early simple blood transfusion followed by an exchange. If it is severe anemia and severe jaundice, like a cord billi more than 2.5, you would do an exchange transfusion. So that will correct the anemia as well as remove the bilirubin as well as the antibodies. Sometimes the anemia can be mild and jaundice not so severe. So in such cases, and some of them present late at 2-3 weeks. So in such cases, you would give erythropoietic stimulating agents like erythropoietin, 400 units per kg, subcute thrice weekly for 2 weeks. And sometimes you can extend for 1 or 2 weeks more, and iron supplementation. So G6PD deficiency is another most common cause of RBC enzyme deficiency induced hemolysis. It is an X-linked recessive disorder. Hence, males would present while females, heterozygous females would be carriers, and rarely X conditions of females can present with G6PD. So what is it? Basically, G6PD is a glucose 6-phosphate dehydrogenase enzyme which protects the RBCs against oxidative stress, which can occur in illness, which can occur due to some medicines, which can occur due to some food like fava beans, naphthalene balls, henna. There's a whole list of medications to be avoided in G6PD deficiency, and the parent and the doctors should be aware of it. Usually we hand over the list to the parent and you should write in bold that this patient is G6PD deficient. The fluoroquinolones and the anti-malarials, primaquine, sulfa drugs are the main ones that need to be avoided. There are some now like paracetamol and other medications which can be given in regular doses. How do you diagnose? With a quantitative and qualitative analysis that is done in all labs, G6PD. What is important is the parent education. Actually, they should be watchful for the signs of anemia and jaundice because of acute or chronic hemolysis. Like they should be told to look for these signs, and if there is any hematuria or pink urine because of intravascular hemolysis, flank pain, all these signs suggest ongoing hemolysis, and they should come for follow-up. And they should be handed over the list of drugs to be avoided. Then there is something which we call as breast milk jaundice. That is a diagnosis of exclusion when the jaundice lingers beyond 3 weeks and there are no other causes, no hemolysis. So it's a diagnosis of exclusion. And the baby is well hydrated and well fed, still has jaundice. So in this case, what happens is the beta-glucuronidase enzyme present in the breast milk can cause deconjugation and increase enterohepatic circulation. Generally, stopping of breastfeeding is not advised unless the levels are really high. Then you just treat with phototherapy and you can try interruption of breast milk for 48 hours. After resuming feeding, sometimes the levels again go up, but they're not so as to treatment threshold, and you can continue, just counsel the mother. What is breastfeeding jaundice? That is because of inadequate intake. There are feeding issues because of the mother or the baby, especially in premature babies who have difficulties latching and establishing and initiating breastfeeding. So they will come with weight loss, the hypovolemia, they would be dehydrated. Labs will show hyponatremic dehydration. So because of inadequate intake, there is slow elimination and then again increased enterohepatic circulation. That is the mode behind the breastfeeding jaundice. So you maintain the hydration and treat the jaundice. So how does neonatal hyperbilirubinemia present? It is of course the jaundice, that is the yellow discoloration of skin and sclera, buccal, gingival mucosa. The scleral and conjunctival icterus is seen in significant hyperbilirubinemia, they say, if it is seen in the first 48 to 72 hours. But subsequently it lingers. However, this finding has not been always consistent. In some studies, there have been lower levels of bilirubin, yet causing conjunctival icterus in the beginning. And of course, you will see the clinical manifestations of the etiology like pallor and hemolysis, bruising, evidence of hematoma as a source, or there can be hepatosplenomegaly in the hemolytic disorders due to ineffective erythropoiesis. So why are we scared of those rising bilirubin levels? Is because there is this consequence of severe hyperbilirubinemia, the neurological consequences. We call it as bilirubin-induced neurological disorders or BIND. Basically, the unbound free bilirubin, it crosses the blood-brain barrier. It can get deposited in the brain tissue and cause cellular apoptosis, molecular damage. Most commonly, it affects the basal ganglia, globus pallidus, and brainstem nuclei for the auditory and oculomotor function. The incidence of these neurological disorders of bilirubin more than 30 mg% is 2 to 10%. So we have the acute and chronic form. Okay. Sorry for the interruption. So we have the acute and chronic bilirubin encephalopathy. In the acute stage, as the bilirubin rises, you should be alert and watch for the neurological signs. Acute bilirubin encephalopathy passes through 3 stages. The early signs would be just a mild hypotonia and a high-pitched cry in the baby. After that, there would be hypertonia alternating with hypertonia, retrocolis, arching back, poor suck, and a shrill cry. As the levels increase and the baby might go in an advanced stage of encephalopathy, presenting with fever, seizures, inconsolable cry, and even semi-comatose. We have a scoring system to monitor it systematically, and if done properly, it would indicate the severity and progress of the encephalopathy. We look at the mental status, the muscle tone, and the cry pattern. And we give a scoring system for 0 to 3, where 0 is normal and 3 is a severe form. So if the baby is sleepy, a score of 1, lethargic 2, and semi-comatose 3. Similarly, a mild hypotonia 1, alternating with hypertonia 2, and retrocolis 3. And if the cry is high pitched 1, shrill cry 2, and inconsolable is 3. So acute would, if not treated, would progress to chronic bilirubin encephalopathy, previously called as kernicterus. Incidence is around 0.5 to 2.3 per 1 lakh live births, and 10 to 25% in those with a total serum bilirubin more than 30 milligram percent. How do they present? Usually in the first year of life with sensorineural hearing loss, movement disorders, gait disorders, tremors, chorea, balismus, dystonia, upward gaze palsy, dental enamel hypoplasia. We've seen that the use of RH isomerization and phototherapy, these are the two interventions which have which have caused a decline in the incidence of bilirubin encephalopathy. So how do you manage neonatal hyperbilirubinemia? We are using the American Academy of latest 2022 guidelines. Those are available for those with more than or equal to 35 weeks gestational age. And we use the NICE guidelines for those with less than 35 weeks gestational age. There are threshold charts for management actually. There are phototherapy as well as exchange transfusion thresholds. A primary goal is, of course, to prevent bind, that is bilirubin-induced neurological. You will screen the child for jaundice and additional tests to see for the etiology, CBC, retic count, G6PD, DCT. And you would start supportive treatment, feeding, hydration. At the same time, initial intervention is phototherapy. And if escalating jaundice, then exchange transfusion. How do you screen? When to screen? Now, American Academy, the latest recommendation is do a total serum bilirubin at 24 to 48 hours after birth or before discharge, which is earlier. Early screening is advised for those with evidence of hemolysis and positive DCT. How do you screen? Total serum bilirubin measurement is the gold standard. In large populations, you can use mass screening with a transcutaneous bilirubinometer and a visual a digital pressure physical examination where we use a Kramer scale. We call it as a Kramer scale to identify those at risk. And of course, I will tell you about the smartphone app Bilimate. So it's a Kramer scale which we use on day-to-day basis to where you apply digital pressure on the forehead or sternum or the skin. And if the levels are between 4 to 6, the jaundice is restricted to the face. If the jaundice is on the chest and upper abdomen, you be assured that the levels are around 8 to 10. If lower abdomen and thighs, 12 to 14, arms, lower legs, 15 to 18, and beyond palms and soles, it is more than 20. So this is a rough estimate. And if required, then you would go ahead with the total serum bilirubin measurement. This is a pic of a transcutaneous bilirubinometer. It's a handheld device and it is used for mass screening. If the levels are high, more than 15, then you confirm with a total serum bilirubinometer. The accuracy is up to 3 milligram percent of the total serum bilirubin levels. And high values will show an error in the reading. So anyways, if you have a reading which is high, you will confirm with a total serum bilirubin. This is the app we made. This is the icon for it. And it takes into account the gestation. You have to enter the gestational age, the postnatal age in hours, and the bilirubin level. And you press on interpret. This is based on NICE guidelines. It's a very useful app, but I think it's a paid one, around $200 for this app. There are others also, Billy Buddy and all, but reliability is not confirmed. So this is very helpful actually, if you don't have anything. Otherwise, what we use is the threshold charts. So once we have done the bilirubin, and if it is not at the treatment threshold, you follow the Bhutani charts actually for risk stratification. That is to understand whom to follow how early. So lesser the difference between the measured bilirubin and the phototherapy threshold, the earlier you would repeat the total serum bilirubin. So like within 24 hours, you will repeat it at 4 to 8 hours. And if as the difference is more, like 5 and 7, then you can call them for follow-up at 2 and 3 days respectively. So these are the this is about the phototherapy units. So this is on the left, we are using the LED blue lights, and this is how the sorry for the interruption again. So phototherapy. So that is a primary that we use begin treatment with. And nowadays we use the LED lamps or blue light in the wavelength spectrum of 460 to 490, where 478 is the ideal, that is advised. And these blue LED lamps are able to deliver that. Earlier, we used to use fluorescent tubes and halogen bulbs. Although efficacy is similar, the side effects of fluid losses and overheating and all are not seen with LED lamps. And commercially available, you can see they are available as overhead lights or beds or mattresses, and even Billy blankets are available. Usually, how do you place the infant in a supine position with eyes and genitalia covered? It is better to give a phototherapy, like we call it double surface, when you give from above as well as below, maximum body surface area to be exposed. The difference, a study has found a difference of 3 mg/% when you give single versus double phototherapy. Should minimize interruptions, especially if the bilirubin levels are more than 20 mg/%. Like even feeding is to be given there with bottle feeding, not to interrupt. The levels are lesser, you can take breaks for feeding and all. What is the dose? It is an intensive phototherapy is the norm. Earlier, conventional phototherapy and all were the terminologies where the irradiance was less, but intensive phototherapy, which means an irradiance of at least 30 microwatts per centimeters per nanometer. We have these threshold charts for phototherapy threshold. These are AAP guideline thresholds for more than 30 weeks. And similar charts are available as advised by NICE guidelines for preterm infants. For preterm infants, those charts are like individual charts from 0 to 14 days for 24 weeks, 25 weeks, and onwards.
Dr. Abhilasha, you have about 5 minutes more.
Okay.
A little less than 5 minutes.
Okay, so audible?
Yes,
Can you
audible.
see the
Screen
screen?
not visible. No, we can see your phone screen. Yes, screen visible.
You can see the screen now?
Yes.
Yeah. So we have the phototherapy threshold charts for more than 35 weeks as advised by AAP, and for preterms we have the NICE guidelines. There are some studies which have an arbitrary recommendations. For preterms, we see that the threshold for phototherapy as well as exchange is much lesser than the term infants. For less than 28 weeks, as early as 5 to 6 milligram% is an indication for starting phototherapy. And this is because preterm have many factors which cause increased bilirubin load as well. Same, but they are more exaggerated. The reasons are more exaggerated, and bilirubin binding capacity is low in preterm because of less albumin levels as well. That is one of the factors, and we use the bilirubin albumin ratio also at some centers are used as for threshold for exchange transfusion, like based on the birth weight, and ratio more than 6.8 is an indication for exchange transfusion. The phototherapy usually converts the bilirubin to more soluble lumirubin form, which is excreted in the urine and bile. And harmful effects are rashes, hyperthermia, some fluid losses, some loose stools that are seen, some interruption of breastfeeding can happen and interfere with the bond. Bronze baby syndrome. This is actually a gray-brown discoloration of the skin, more seen with conjugated hyperbilirubinemia when treated with phototherapy, when the levels are more than 2 milligram%. And it is harmless. It is not neurotoxic and usually resolves within few weeks. So it is not an indication to stop phototherapy. Long-term effects are retinal degeneration, seizures, and others. So you should monitor the hydration. You should repeat total serum bilirubin 6 to 12 hours later and stop phototherapy once the levels are more than 2 milligram% below the threshold, and 3 in preterm infants. You would expect a 25 to 40% reduction in the bilirubin. What is rebound hyperbilirubinemia? After stopping phototherapy, it's recommended that repeat total serum bilirubin 12 to 24 hours later. Rebound hyperbilirubinemia can occur and usually within 72 to 96 hours if it occurs after stopping phototherapy. So you would treat according to the thresholds again. If it is not responding, you would go ahead with escalation of treatment. There's a new modality, filtered sunlight, I would like to tell. This is not direct sunlight. Direct sunlight definitely not recommended because it causes hyperthermia, fluid losses and all. There are commercially available window tinting films which will transmit the blue light while filtering out the UV and the infrared light. That's a filtered sunlight. Just a word or two about exchange transfusion. As we know, signs of bilirubin encephalopathy and serum bilirubin crossing the exchange threshold. You would do the labs, or meanwhile waiting for the exchange. If you can give IVIG in immune hemolysis 500 mg per kg while you're buying time over 4 hours. A double volume exchange 160 ml per kg. You should give whole blood. Whole blood is not available. A mixture of RBCs and fresh frozen plasma with a hematocrit of 40 to 45% is ideal. And you do it by push-pull method. We cannulate the umbilical vessels and push blood through the umbilical vein and withdraw through umbilical artery in aliquots of 5 to 10 and 20 in term infants. Phototherapy is continued during the procedure. Monitor the vitals, send lab before and after. Usually after 2 hours, the bilirubin levels would reach again the pre-treatment threshold because there is an equilibrium formed between extravascular and vascular bilirubin. So the levels reach after 2 hours around 2/3 of the pre-exchange values. However, immediate exchange, a successful exchange will definitely reduce 50 to 80%, 85% as compared to pre-exchange values. What are the complications associated with cannulations, thrombotic complications, portal vein thrombosis, cardiac arrhythmias, electrolyte imbalances, anemia during withdrawing of blood, bloodborne infections, and necrotizing enterocolitis. Last word is about prolonged jaundice, the one which exceeds more than 2 weeks in term and 3 weeks in preterm infants. Mostly surgical causes are seen, a direct or congenital hyperbilirubinemia, and they need to be worked up. For that, you can look for pale stools, dark urine. Would send a CBC. You can look for ongoing hemolysis sometimes, but DCT, inborn error of metabolisms are common causes, and you should do a metabolic screen. And finally, take a surgical opinion, especially biliary atresia and all. Thank you.
Thank you, Dr. Abhilasha. Our next speaker is Dr. Manju. Dr. Manju is a neonatologist and pediatrician with 12 years of experience. She's done her MD from Nair Medical College and DM Neonatology from Sion, with fields of expertise in neonatology and pediatric medicine. Over to you, Dr. Manju. If you could just share your screen.
Yeah, I'll just wait for stop sharing the screen from Dr. Abhilasha. Okay. Is it visible now?
Yes, your slides are visible.
Okay, good afternoon, everyone. So, thank you, Dr. Ruzul, and thank you, Dr. Abhilasha and Roshan, for the nice presentation. And as Roshan said that she has presented the desert before, so I guess that this presentation will complete the meal. So I'll discuss today developmentally supportive care in NICU. And before we start the discussion, let us ask ourselves whether what are our thoughts on what are the importance of developmentally supportive care in NICU? What are our goals that we want to achieve? And what do we feel that whether it helps in neurodevelopment or it is just a part of care which can be taken lightly and not taken care of. So as the survival of neonates have increased over the time, the focus has shifted merely from the survival to the intact survival. And what we mean by intact survival is that the quality of life of the babies, particularly the preterm babies, should be improved over the time. And it is not something extraordinary, but as we see in the nature, all the organisms, all the individuals, infants are supposed to be nurtured in an optimal environment for their proper growth. But with the time, it has been seen that as we have improved in the survival of the premature as far as low as 20, 22, 26 weeks of gestation, their survival have increased, but the quality of life have not that much improved. And in various researches, they focused on this part of the neonatal care, and they found that developmentally supportive care should be an important part of the care as it has a long-term impact on the neurodevelopment of the neonate. More than 96% of the premature low birth weight babies are born in developing countries, and India is a major part of it. And the premature babies are at high risk of altered brain structure and functional development, which influence their long-term outcomes. We'll see it further how it is affected in the neonatal period. As we see the schematic chronology of the major events during the human neocortical development, we see that it starts from the 3rd gestational week and it goes on till many postnatal years, but particularly till the 3 years postnatally. In initial 20 weeks, as you can see in the chart, from 20 weeks gestational age to 3 years of age, there are multiple processes going on, that is synaptogenesis, gliogenesis, myelination, angiogenesis. till 20 weeks, there is not much of a sensory reception, but after 20th week, there is a lot of sensory reception, and which plays the part in the synaptogenesis and other neurological maturation process. And this is the very critical time in which the care, the environment we provide to the baby becomes very important. And this is the critical time when we have most of the babies in the NICUs. So we will see that what are the differences between the intrauterine environment and the environment that we provide. So intrauterine milieu consists of the generalized flexion and gentle, secure containment within the uterine wall. It has very limited light and noise exposure, particularly up to the 32 to 34 weeks when the uterine wall is thick. And after that, it becomes slightly thinner, and there is graded amount of increase in the light and noise exposure. Baby has a normal sleep cycle preservation inside the intrauterine wall, and there is unrestricted access to the mother via the somatosensory, chemosensory, and the auditory pathways. In contrast to that, when the babies are born and at this fragile gestational age, and they are brought in the NICU environment, there is a lot of fluctuation in the oxygenation and nutrients, and there is fluctuation in the temperature, and as the number of babies are touching, they are touching number of surfaces. So there is a lot of variation in the tactile stimulation, the position and the handling, multiple ways of handling. They have various vestibular sensory inputs, the pungent smell of the cleaning liquid, the spirit, all this olfaction stimuli, various gustatory stimuli, and a fluctuation in the auditory and visual stimuli. All of they are exposed to all of these overstimulation, and that affects their neurodevelopmental outcome. And then the question arises, why developmentally supportive care? What is it? How we should provide it? And what is its role in the neurodevelopment? Our goal should be to provide a neuroprotective care. As I had told earlier, the focus has now shifted from mere survival to the intact survival. Intact survival means we provide an environment which provide the neuroprotection, and there is an improved neurodevelopmental outcome. And particularly to these preterm and critically ill infants. So what is this? What is this developmentally supportive care? These are the evidence-based interventions and processes that supports the newborn brain and neurobehavioral development. They support the autonomic stability, the normal motor, sensory, neurological development, and it promotes the behavior state organization. One by one, we will see what all this means, how we provide this developmentally supportive care. So basically what we do in this supportive care, we assist the infant in the NICU and we respond to their cues, whatever they are trying to say. How we assess them? So in the assessment, we should know what is the well-organized infant and what is the disorganization or not well-regulated infant. So when we talk about the not well-regulated infant, they show the stress behavior. This stress behavior can be seen in the form of either the autonomic stress behavior, the motor stress behavior, or the attention stress behavior. In the autonomic stress behavior, there are changes in the heart rate, respiratory rate, saturation, blood pressure, color changes. They may show the gag, they may show hiccups, or sometimes you must have seen that when you are putting an IV or there is a painful procedure, or when you are just examining the baby passes a stool. They may sneeze, they may yawn. These are all the autonomic stress behavior. And when we monitor these, we chart them that what stress behaviors they are showing. Apart from that, there are multiple motor stress behavior that you must be aware of. So some babies may show a salute sign, that is just putting the hand to their face and saying that please stop, don't disturb me. Or they may show the splaying of the fingers, or they may tighten all the forelimbs. Sometimes it is tightening all the forelimbs, looks like they are sitting in the air, or the arching of the back. Apart from that, there may be tongue thrusting, or there may be extension of all the limbs. So this kind of behaviors are seen in the motor as a motor stress behavior. Apart from that, there are interaction stress behavior. When you have been there, you are performing some examination, or you are in the environment, you see that baby is having gaze aversion. He is saying that don't look at me. I'm not liking what you are doing. They may show hyper alertness. They may cover their eyes. So all these are the stress behaviors that the infant show because of their dysregulation. In contrast to that, there are self-regulatory behavior, which are shown mostly in the near term or term babies after 35 weeks. So when the baby is more than 35 weeks, they develop certain self-calming or self-regulatory behaviors, like grasping the finger or the wire or the things beside them. They may themselves, after an oxygen stimuli, after stress, what they will do, they will try to put themselves in a flexed posture, or they will put their hand to their mouth. They may start sucking their hands, or they may put their hand to their face. So these are the self-regulatory behavior, but these self-regulatory behaviors develop after the baby attains certain gestational age, that is mostly after 35 to 36 weeks of gestational age. So how do we provide this developmental care? So various studies or various researchers have proposed various care models. So this is one of the care model in which there are 5 core measures of developmental care were considered, proposed by Colin M. And they considered the 5 core measures, that those are protected sleep, pain and stress management and assessment, developmentally supportive activities of the daily living, family-centered care, and the healing environment. In line of that only, the other models were proposed, like the Neonatal Integrative Developmental Care model by Philips Healthcare. They consider it as a lotus flower with healing environment as their center. And apart from that, there were 6 others care features, like the partnering with the families, the positioning and handling, safeguarding the sleep, minimizing the stress and pain, protecting the skin, and optimizing the nutrition. Apart from that, you must be aware of the NIDCAP nursery model. So here there is interdisciplinary goal setting, and then regular training of the staff, the parents, and the people who are involved in the care of the baby. And there is a recurrent mentorship program that is done by this NIDCAP association, and they provide that NIDCAP nursery level to the nursery. So there are various models that has been proposed, but the core of this are the same, that the babies should be provided the self-regulation, or baby should be in a state of organization. So what are the general principles? To the core of general principles are the education and mentoring of the parents and the staff. When you are meeting a baby, greet the baby, or have a positive stimuli to the baby. Gentle handling using calming techniques, which we are going to discuss later, and creating and implementing an individualized developmental care plan for each infant. So each infant should be assessed individually, and what their requirement is, we should respond to that. Providing the guidance to the parents on how to create and sustain a healing environment. When renovating an NICU, as a pediatrician and neonatologist, we should advocate for the optimal family support spaces and individualized infant spaces in the NICU structure. So one by one, we will talk about that. So first and foremost, we'll talk about this Lotus model, and in which there is healing environment, which consists of as we can see that there are 5 components: the light, sound, taste, smell, and touch. One by one, we'll talk about that. So we see that these receptors, all these 5 senses, this is receive the sensory input, and that is processed in the cortical system or the neurological system, and with multiple interaction along with the nutrients like iron, iodine, taurine, and various amino acids and micronutrients, they interact internally, and that ultimately results in the positive brain wiring. If anything is disrupted, right from the receptor system and nutrients to the environment and the sleep-wake cycle, if there is any disturbance, there will be disturbance in the brain wiring, or we call it a synaptogenesis and further brain maturation. So when we talk about the healing environment, when we talk about the touch or the tactile stimuli, then we should provide a neutral thermal environment for the babies. First step in that, if the baby is extremely low birth weight or extremely premature, we should provide a proper humidity during first 1 to 2 weeks of the birth. Skin to skin contact, again and again, this topic will come in this presentation. Skin in skin contact is, as per the Kangaroo mother care, it is very, very important right from the birth. As we can see that what WHO defined the skin to skin contact is when an infant is placed prone on the mother's abdomen or chest in direct ventral to ventral skin contact, it is called skin to skin contact. But of importance, there are certain things. It should be provided in less than 10 minutes after the birth, that is called immediate skin to skin contact, that is advocated nowadays, as compared to the early skin to skin contact, in which it can be provided anytime within the 24 hours of birth. So the emphasis is now as early as possible. And at least 60 minutes. Many a time we see in the NICU that when we will ask the parents, they will say that, yeah, I am providing the kangaroo mother care. So if we will go in detail, how much time had you given? Oh, we give it for 10 minutes. So 10 minutes is actually harmful for the baby as compared to the useful to the baby, because the normal sleep cycle in these preterm babies are approximately 45 to 60 minutes. So whenever you are advocating for the skin to skin contact, always continue with that it requires at least uninterrupted for 60 minutes. And for the other stimuli, like the vestibular stimuli, so when we are handling the baby and changing the position of the baby, they receive the various vestibular stimuli. So change the infant's position gently and slowly without sudden movements. Whenever we see in NICU, sometimes changing diapers, what we see that the caretaker or caregiver, they are lifting both the lower limbs and then change the diaper. This lifting of the lower legs has seen that there is increase in the venous return. I provide not a very positive or negative vestibular stimuli also to the baby. So even in the changing of the diapers, advocate for the slight turn change the diaper in the side position as compared to the lifting the legs and then removing the diapers. So whenever we are changing the infant's position, it should be gentle and slow without sudden movements. Olfactory stimuli, maintain a scent-free and fragrance-free unit. Make it a policy that this unit, the scents and fragrance are not allowed. Train the staff that they are not allowed to open the pungent smell cleaning liquid near the infant care areas, or any pungent smell liquid near the infant care area should not be allowed to open. And along with that, certain units practice this, exposing the infant to the mother scent with the breast pad or soft cloths. We advocate for the kangaroo mother care, which provide all this stimuli, as we'll see later. As per with the positive stimuli, it's a provide the colostrum or express breast milk and oral care protocol. As per protocol, oromotor stimulation and non-nutritive sucking can be started from 28-29 weeks postmenstrual age onwards, when the baby is stable. And position infant with the heads and head near the face. Basically, the midline positioning is what advocated. We will come to it later also when we will discuss the positioning. And in the auditory stimuli, there should be consistently calm environment. When we are providing this developmentally supportive care, what we are doing, we trying to mimic the environment in which baby was supposed to grow. So baby was supposed to grow in the intrauterine environment, and the same environment we want to provide in the NICU. Our aim is to provide the same environment in the NICU. So consistently calm environment with muted sounds during the caregiving interaction should be aimed at. Monitor the sound level if possible with an average sound level of 45 to 55 and upper limit of 65 decibel in the infant care area and 70 decibel in the family area. So basically practically what we can do is just hush or small rounds around the patient or the infant, and then the detailed round or where the discussion should be held in a separate area away from the infant care areas. The audible alarm should be silenced as quickly as possible. Of course, after taking the appropriate measure should be taken, and just alarm should not be silenced. But it should be silenced as quickly as possible, and wherever possible, use the visual alarm systems, which are available nowadays in almost every monitoring devices. Expose the infant to the audible maternal and paternal voice. So whenever we should actually encourage the parents to talk to the babies, to sing to the babies in normal, quiet, lower tone. And you can see that this kind of devices are also available, where it shows the green, yellow, and red color whenever the decibel goes in a particular limit, crosses a particular limit. Similarly, the visual stimulation, as you can see that in a particularly designed NICU, in a developmentally appropriate NICU, there should be ambient lighting. So the NICU environment, the level of light should be approximately 10 to 60 lux. So that will be like lighting or ambient lighting should come to the NICU. Whenever an infant is needed to be examined, there should be an overhead light which is directly above the baby, and it should not spread to the other area. And when we switch on it should be concentrated over the baby. And the level of this light should also not be more than 600 lux. And whenever the procedural requirement, when we require more than 1000 lux, it should be available in the warmer kind of devices. So it should focus on the babies. And whenever we are using the procedural lights or the lights higher than 600 or 1000 lux, at that time we should gently shield the infant eyes during the care if the overhead light is needed. And apart from that, it is of actually a lot of importance, because before 37 weeks of gestation, it is not that if we stimulate this visual system, it will lead to a better development. Generally, this is the notion that as much stimulation we will provide, it will provide earlier maturation of the system, but it does not happens with the preterm babies, and particularly with the visual stimulation. If we should minimize the purposeful visual stimulation till 37 weeks of gestation, after maybe 32 to 34 weeks of gestation, some lights may be exposed to some lights, and after 37 weeks of gestation only they are supposed to see the cards, that contrast cards and all. So as much as possible, keep the visual stimulation low. So these are all the sensory stimuli which should be taken care of in the healing environment. And master of all these measures is the kangaroo mother care. As we can see in the kangaroo mother care, it provides all the stimulation, all the positive stimulation that wires the brain. Baby can see the mother's eyes, it can smell the mother's milk, it can taste the mother milk, and so the gustatory, olfactory, the visual, it is in direct contact with the mother's skin, so the tactile stimulation is there, and the movement, the mother's respiratory movement will be there, so baby moves, and it provides a positive vestibular stimuli. And if we can encourage the mother to talk to the baby or sing to the baby, and that will be providing the positive auditory stimulation. So you can see that this is the master of all the positive stimulation, that is the kangaroo mother care. And it provides a lot of benefits to the baby, along with the multimodal stimulation that we talked in the developmentally supportive care. And apart from that, it helps in the earlier growth spurt, better IQ, better stabilization, physiological stability, autonomic stability, and developing a better sleep cycle. Over the years, in multiple systematic review of literatures and meta-analysis, they have shown that it is very beneficial in the long-term neurodevelopmental outcome. And in some studies, they have followed these babies for 20 years, and they have shown that they have a long-lasting social and behavioral protective effect even after the 20 years of their intervention. Recently, this was the WHO study in which the immediate kangaroo mother care, when the baby is ready, even the baby is unstable, if the mother is ready, immediately the kangaroo mother care can be started besides the intensive care. And it has shown that it has improved the survival, but they had studied the babies who are between 1 to 1.8 kg, and they found that the survival rate and other stability features have improved. Their long-term outcome will yet to be studied, but this is also a very positive study in terms of the kangaroo mother care. Then the next component is the partnering with family. So here in the NICUs, family is not mere a visitor. They are the part of the care, and this has a very long-term impact in the neurodevelopmental outcome. So if we see the various studies, it shows that separation dysregulates. When the parents and infant are separated in the initial period, there is dip in the growth hormone, there is increase in the stress hormone like the adrenocortical hormones, and this regulates, and this disturbs the homeostasis of the baby. And in another study, it has shown that initially, particularly, actually this is more for term babies or near-term babies. Initially, when the babies will be separated, there will be calling, searching, there will be anxiety, protest, and ultimately it will. It sounds very different, but babies also go in the depression and show the detachment. And this protest, despair, dysregulation, ultimately it leads to the altered neurobiological system, and this is not curable. So as a pediatrician or neonatologist, when we care for a baby who are in such a vulnerable stage where their brain is still developing, we are catering for a special population. So we should be aware that what we are providing is not just the medicine and the intervention, but a care environment is very necessary for these babies. So when we are talking about the principles of partnering with families, family-centered care is supported as soon as the NICU care stay is anticipated. Encourage minimal separation between the parent and infant. Make your NICU parent friendly. Allow them 24 hours a day. Support the families with the warm and respectful manner. Actively listen to them. Accommodate their presence in the NICU. And communicate about the infant's medical, nursing, and developmental needs. Support the breast milk expression. When the mother will be present almost most of the day beside the baby, her breast milk output will increase. The kangaroo mother care will increase. Kangaroo father care should also be advocated when the mother is sick or if not available. The oromotor stimulation, non-nutritive sucking, this all improve, and that all decrease the NICU stay. They improve the development of the baby. They improve the achievement to the full oral feeds. All those increase with the partnering with the families. And so the next part in this supportive care is the positioning and handling. So there are various positioning techniques, like whether we should position them to the supine, the sideline position, or the prone position. The goal is to maintain the optimal tone and position, and to remain in a quiet, restful sleep. So ultimate aim is the quiet, restful sleep. It has been shown that babies are least stressed in the prone position when they are nested in the prone position, and their respiratory stability and autonomic stability is also very good in the prone positioning. Although I know that supine position is advocated when the babies are discharged to the home, but when they are in the NICU in a monitored environment, the prone or the sideline position is less stressful for the baby, and it is better for their development also. So the key points are: support the head in midline, whichever position, whether it is the baby is in supine, whether it is in sideline, or they are in the prone position. Support the head in the midline, neck in the neutral position, round and forward shoulder, and symmetrical flexion of the trunk. Hip and knee should be flexed and as much adducted as possible. And use small diapers, because if you will use the large diapers in a small baby, it will lead to the abduction of the lower limbs. Support the foot position in the neutral way. So there should be nest with elevated boundaries, and it should support the foot position. It should support the position of the baby in the flexed manner. Whenever we are handling the baby, always provide a four-handed support, means two people should be involved during the positioning and caring activities. Promote the hand to mouth, basically the midline activities. Promote the hand to mouth or hand to face contact. Collect all the supplies prior to approaching the infant. It is not that you have approached the baby, now you have opened everything, and then you are thinking whether now I should open where is the IV cannula, where is the saline. So first collect all the supplies and then approach the infant. Disturb them as less as possible. Seek another person to support the infant care. Support the infant care during a potentially stressful experience like bathing or weighing. And actually, if the parents can be involved in this kind of activities, the daily caring activities of the baby. And it is good to utilize a validated and reliable positioning assessment tool like the IPAT, Infant Positioning Assessment Tool. It ensures the appropriate positioning. It is a pictorial diagram, and there is a scoring between scoring up to 12. 10 to 12 is considered as optimal, and it should be targeted. And it ensures that there is appropriate positioning, and it encourages the accountability on the part of the caregiver. Whoever the staff is allocated to the infant, she'll see that whether the baby in each shift they can see whether the baby is appropriately positioned or not, and they can score, and they will target that for the 10 to 12 scores. So this can be helpful. So these are the different positions in which babies can be kept. So there should be a nest around. They can also be contained with the extra cloth over them. And in the sideline position, in the supine position, everywhere the baby should be properly flexed. There should be a proper boundary, and baby should be cared in these positions. The next is safeguarding sleep. And of all the whatever components we are discussing about the developmentally supportive care, this is the most important component. The key points are to recognize and protect the sleep cycles. So we should monitor the baby when the baby is awake and when the baby is asleep. So first we have to recognize and protect the sleep cycles, especially the REM sleep cycle. So that is why I was discussing when we were discussing the kangaroo mother care or skin to skin contact. Do not disturb the baby before their sleep cycle is completed. So basically it is 45 to 60 minutes at least. If the baby is sleeping, do not disturb them every 15 or 20 minutes, and recognize their sleep cycles and accordingly plan your care activities around them. So here comes in play the cluster care activities. Basically, when the baby is awake, cluster your activities, the weighing, the bathing, and changing the position at that time. Do it at a time, and then when the baby goes to sleep, provide them the sleeping opportunity for next 2 hours or 1.5 to 2 hours at least when they are their next feeding or caring activities will come. And during providing these care activities also, actually, you have to monitor the baby where they are showing any stress signs. If they are showing any stress sign, the important activities should be performed and non-important activities should be kept for the next caring activity. Many of the hospitals have adopted this octopus therapy where they see that it helps in the infant in being in a well-organized state with good self-regulation and sleep state. The principle is that the tentacles of the octopus behaves like give them the feel of the umbilical cord. So there can be multiple innovation to mimic the intrauterine environment, and octopus therapy is one of them. The other is the minimizing stress and pain. So to minimize the stress and pain, use a formatted tool for assessment of stress. Neurobehavioral scale, Brazelton scale can be used for that, self-regulation and sleep states. Use a reliable pain assessment tool like the PIP or the NIPS, and have a pain management protocol in the unit when you are going to do what. Identify the processes and interventions requiring the pain management, the non-pharmacological methods like swaddling, facilitated tuck, KMC. The staff should be trained in all that if they are posted in NICU. The breastfeeding, NNS, pacifier, 25% dextrose. These are most common methods of the non-pharmacological measures which are used for the pain. Sometimes they need the pharmacological measures like the fentanyl infusion or the MLA cream like activity. So if possible, provide swaddling to the baby when they are showing the stress sign to minimize their stress. When swaddling is pretty common in this part of India. And but the way we swaddle, we should remember that the core of this positioning, handling, and minimizing stress is the flexed posture. It is the flexed posture in the intrauterine environment. So train your staff that they should not extend all the limbs in a tight position and swaddle the babies. Rather, they should swaddle the babies in the flexed position, and some amount of movement should be allowed inside this swaddling. And so that will also decrease the chances of the hip dislocation. And basically, that is the core measure where flexed posture is needed. Facilitated tuck. So facilitated tuck is another containment measure in which if the baby is showing the stress sign, then you keep one hand firmly on their head and another one on the buttocks or the legs if they are in the supine position, and you firmly keep that in that way, and that actually brings the baby back in the regulated state. So these are certain measures of the containment and minimizing their stress. Then another component is protecting the skin. Is this kind of preterm newborns who are very preterm in 26, 28, their skin is very fragile, and they are at a very high risk of losing their skin integrity in the NICU. So utilize a skin assessment tool on admission and routinely at least one per shift. There are various skin assessment tools available, Brandon Q scale or newborn skin care scale or NSRAS. They can be used. One of them can be used in the unit, and provide additional humidity to the extremely low birth weight infants during the first 1 to 2 weeks. As we had talked, they should be either nursed in the incubator for initial 1 to 2 weeks, or if they are in the open warmer care, try to provide the kangaroo mother care if possible. That is the best way. And that is the best way to provide the warmth and humidity to the baby, a proper optimal environment, or there can be some cling wrap can be used below the warmer to provide the additional humidity or prevent the loss of water from the ELBW babies. Provide appropriate positioning support utilizing the gel product. Sometimes there may be, if the baby is in the same position, there are chances of the bed sores. So the key is to change their position minimally every 4 hours or with the care. So here the cluster care is important. Whenever you are caring for the baby or changing the position, try to do all the care activities during that time. And at that time, change the position of the baby when you are providing certain cares to the baby. But minimally every 4 hours, the baby's position should be changed. And if you are seeing any signs of the skin breakdown, utilize the gel products and other positioning aids to prevent the skin breakdown. it is, I will not say it is very common, but it is many a times seen that the position of nasal prongs, they are very tight, or they lead to the injury to the nasal skin when the baby is requiring the respiratory support. So examine the position of the nasal prongs, whether it is very tight or very or it is in the comfortable position. Minimize the use of adhesive. Whenever you are using adhesive, use the tegaderm or duoderm in the initially, and then use the micropore or other adhesives. Use caution when you are removing the adhesives. It should not be ripped off. The skin will ultimately be ripped off, and it will lead the skin will lose the integrity, and actually it increase the chance of infection. Also, it provide a negative stimuli. Also, it has the with this kind of pain, there is behavioral disorganization. It has a long-term effect if the baby is exposed again to this kind of the negative stimulus. Change the saturation probe sites so that so to avoid the skin burns. Then the other component is the optimizing nutrition. Kangaroo care, again, the aim is early initiation of feed or establishment of breastfeed. So it is the best modality to optimize every developmentally supportive care. Promote the positive oral and olfactory stimulus during the early skin to skin contact by NNS that can be started as early as 28, 29 weeks of gestational age, postmenstrual age, and minimize the negative perioral stimulation. Suctioning without giving any pain measures that may lead to, you will see that many of the babies just refuse to feed. They have the feed aversion because they have a very negative stimulation, very negative oral stimulation during their intensive care, suctioning, intubation, and all. They lead to a very negative oral stimulation, and that may lead to the feed aversion in long term. And when the baby is discharged from the hospital, they are not able to take the feed, and they may have an exaggerated gag reflex and they may need the swallowing therapy because of these negative stimulation. Early enteral nutrition is important as early as possible. Have the provision of the enteral nutrition for the babies. Early and frequent expression of breast milk should be supported, and if it is possible, the cue-based or infant-driven feeding should be supported for the babies who are slightly off the term age. So babies should be feed with the feeding cues, and it is always advisable that the cues should be identified, and baby should have the cue-based feeding rather than the time-based feeding. So these are like early cues of the babies and mild cues. The staff and the parents and the caregiver should be aware of these kind of cues and how they should feed the baby. Support and encourage the mothers express breast milk supply. So initially when the babies are not on feed or are in intensive care units, at that time also encourage the mother to express the milk so that their milk supply is encouraged and their milk supply is whenever the baby requires, they have the adequate mother's milk. Provide the donor human milk if the mother's milk supply is not adequate or if it is not possible for the extremely low birth weight babies. Apart from the decrease in the infection and the necrotizing enterocolitis, it has effect on their IQ and brain development also. Support and encourage the breastfeeding well before the discharge. So before the discharge, ensure that every mother knows that breastfeeding is importance of the breastfeeding and also how they should encourage and repeated. These things have to be told repeatedly again and again when the impact is long term and not a very short term impact is there. Then it becomes important that we as a care provider should encourage again and again this the breastfeeding and these activities. So this ingest all the components of the developmentally supportive care. How to provide that? So as a NICU policy, it has been advocated that it should be developmentally supportive care should be recommended in all the NICUs, and we can provide it as a quality improvement, provide the staff the required information, the training, and implement as a quality improvement project, or maybe we make a bundle care kind of project like DSC bundle care 1 for full implementation at around 26 weeks of gestation, or bundle 2 care between 31 to 32 weeks of starting at 31 to 32 weeks of gestational age, where categorization of the different activities can be done based on their appropriate gestational age. So to summarize all this developmentally supportive care is a low-cost, non-pharmacological intervention. It does not require any extra staff. It improves the short-term and long-term neurodevelopmental outcome in the baby. And it is a very important neuroprotective measure which does not require much of financial or other inputs, but requires a lot of motivation and knowledge. Basically, everyone is in the support of the babies, actually, for their intact survival, for their better outcome. And if they are provided that information, the parents and the staff and the professionals, I'm sure that they will be interested and they will make their NICUs developmentally supportive. So I'll conclude over here, and I hope that it has provided the sufficient information. And thank you. Thank you very much.
Thank you, Dr. Manju. Our next speaker is Dr. Sarita Bhagwat, ma'am. Ma'am has about 25 years of experience in the field of pediatric surgery. Completed her MBBS, MS General Surgery and MCH Pediatric Surgery from KEM Hospital and St. GS Medical College. Ma'am will be talking about neonatal surgeries. Over to you, ma'am. Dr. Manju, let's stop the screen sharing.
I'll make 700 grams daily.
Hello, can everyone hear me? Hello.
Yes, yes, yes.
Well, somebody has to put the slides on. Hello.
Yes.